Good morning, good afternoon, and maybe good evening, depending where you are, to everybody. Thank you so much for joining this session on COVID-19. We have three excellent papers that will be presented, giving us different perspectives on the challenges that persons with disabilities face during the COVID-19 pandemic. And since we are short on time and I have been requested to be very strict in keeping us on time, I'm going to pass to the first paper. Its title is Ventilator Users in the Time of COVID-19, and the paper itself is called Not My Ventilator. With this said, I'll pass the word to the first presenter, Brooke Ellison. She wrote the paper together with Michelle Ballan as well. So Brooke, please go ahead.
Thank you, Maria. Good morning, everyone. Just give me 1 second to share my screen. Okay, can everyone see already? All right.
Yes.
Terrific, great. Yeah. So as Maria mentioned, I'm here to present the paper "Not My Ventilator: A Critical Look at New York State's Ventilator Reallocation Guidelines." It's a paper that I co-wrote with my colleague, Dr. Michelle Ballan, and we're both from Stony Brook University. Just 1 second.
Still advancing.
Okay, so at risk of stating the obvious, we are in the midst of a pandemic like we have not experienced in well over a century. And as a result of the pressures of COVID-19, we're taking a much more kind of critical look at how people of different from different backgrounds are disproportionately affected by the pandemic, and how we need to be much more particular in the ways that we look at the distribution of scarce resources in a time of a pandemic. The utilization of healthcare is much more extreme than it would typically be in any other point in time, and we have a limited amount of resources, a limited amount of healthcare resources, and often the utilization is so high that that those who need care can't always get the care that they need. And this has been borne out in many different ways over the course of the past year or so, but in no more particular instance than in this instance of ventilator allocation and how we should allocate the use of ventilators, given that people who are afflicted with COVID-19 might need to have access to ventilators in order to breathe. And these are the kind of decisions that are very difficult to make, that that medical as assistant physicians have had a very difficult time trying to grapple with. Fortunately, there have been people who have been thinking about these questions for quite some time. So just to give a little bit of background, in 1985, the New York State Department of Health put together a task force, and they called it the New York State Task Force on Life and the Law, which was designed to look at very difficult bioethical questions as they relate to instances of life and death. And as a result of the H1N1 pandemic in the early 2000s, they were looking at how in a time of a pandemic, especially one that is respiratory in nature, how we would distribute ventilators to those who might need them when they might be in short supply. So these are life-saving technologies that, unfortunately, there's not enough to go around if a pandemic like the one that we're facing right now might hit, when many people would need the assistance of ventilators to breathe, and there simply would not be enough to go around. So they were thinking about these questions way back in 2007. In 2015, so still preceding this current pandemic, there was an update to the guidelines that the task force had originally drafted in 2007 to put into place additional ethical protections. So the original guidelines were drafted with mindfulness to the ethical concepts of duty to care and duty to steward resources, but there was a fear that that would not be enough, that those ethical parameters would not be enough to protect the lives of those who might need ventilators and those who are particularly disadvantaged from a lot of decision making, namely people with disabilities, the elderly, and the like. So they implemented additional ethical protections in the form of a duty to plan, distributive justice, and transparency. So those guidelines have been in existence since 2015, and now here we are, 2019, when the coronavirus pandemic hit. So it was, to everyone's benefit that the New York State Task Force on Life and the Law had put together guidelines on how different healthcare institutions and physicians could allocate ventilators in the time of a pandemic. But the updates were to protect everyone, to protect especially people with disabilities and those who are typically marginalized from decision making. But people who are chronic ventilator users have been quite concerned in how these guidelines might disproportionately disadvantage them. So a chronic ventilator user is somebody actually like myself whose existence is completely predicated on the reliance of a ventilator. So their breathing is reliant on medical assistance, mechanical assistance in the form of a ventilator because of respiratory failure. And whereas in years past or in centuries past, people who experience conditions that would make them likely to live on a ventilator would typically pass away, now because of medical innovation and medical progress, they're much more likely to live. So chronic ventilator users are growing in number, and they are much more community dwelling, right? So they're not necessarily always living in medical institutions or hospitals, but living in the community themselves. So like I mentioned, the update to the ventilator allocation guidelines that were implemented or designed or drafted in 2007 by the New York State Task Force on Life and the Law were directed in 2015 to protect those who might often be disadvantaged or biased against when it comes to the allocation of scarce medical resources. And so they wanted to protect the elderly. They wanted to protect people with disabilities and those who are in lower socioeconomic statuses. They wanted to implement a structure or a framework that would be objective, that would remove bias that is often implicit when it comes to medical decision making. And the approach that they took was to implement something called SOFA, or a sequential organ failure assessment, to create a completely physiological, non-partial, impartial measure to determine somebody's success when it comes to the use of a ventilator, so that there's no bias at all introduced. So what is SOFA? So SOFA is a score that has been created or implemented by emergency room physicians, ICU physicians, to essentially measure the likelihood of somebody surviving. It estimates mortality based on a series of factors, including oxygen saturation, platelet count, liver function, mean arterial pressure, renal function, so many physiological measures of overall body function. What is interesting is that one of the factors that's used, so there are points ascribed to somebody's, for instance, oxygen status or platelet count or what have you. One of the factors that's taken into account, though, is mechanical ventilation. I'll talk in a bit about what the consequences of that might be. So in the case of a respiratory pandemic, patients are triaged essentially according to these guidelines into 4 different categories. Blue for those who are likely not to survive no matter what kind of medical intervention they might receive. Green who are those patients who are sick but would not require the use of a ventilator. Red, those who are likely to survive if they received a ventilator, and then yellow, somewhere in between red and blue, so people who it's kind of questionable whether or not they would survive given a ventilator. So that's kind of how the process is supposed to work. They assess somebody's SOFA score and then put them into one of these 4 categories and allocate ventilators accordingly. So, like I mentioned, one SOFA score is, or the SOFA score is contingent on the presence of mechanical ventilation. So people who are chronic ventilator users are, in essence, duplicatively disadvantaged. First, by the presence of living on a ventilator makes them more likely to experience some kind of respiratory pathogen, and at the same time, their ability to get a ventilator that they might need is reduced by their living on a ventilator to begin with. So that makes them disproportionately disadvantaged, in fact, implicitly and duplicatively disadvantaged in this overall scheme to allocate ventilators to begin with. And given the structure of the guidelines, there's been a lot of concern among ventilator users that the guidelines would disadvantage them all more than they were already disadvantaged, given the nature of the pandemic that we're experiencing right now. There was just a significant lack of clarity in the guidelines. In fact, the guidelines explicitly state that a chronic ventilator user should he or she enter an acute care setting, it runs the risk of having his or her ventilator reallocated to somebody else. And that lack of clarity, the fact that that statement is in those guidelines to begin with, has stoked considerable concern among ventilator users that their own ventilator might be given to somebody else if they would have to go to the hospital for any medical condition, not necessarily even one that's related to the pandemic itself, but any medical condition. And if that were to happen, if somebody were to have his or her ventilator reallocated to somebody else, that would necessarily result in his or her death. Additionally, stoking concerns and fears about being at risk for any number of medical complications.
Brooke, just stress that you have 2 minutes to conclude your presentation.
Sure. So all of the additional ethical considerations that were put into the revised guidelines are, in essence, reduced or eliminated, given the potential effects they have on the lives of people who are chronic ventilator users. It's a failure to plan, right? That we could conceivably avoid this problem by creating more ventilators, by making sure that we have a stockpile of ventilators should we need them. It's a violation of a duty to care. So people who are on ventilators who have been very kind of concerned to go to a hospital setting should they need care because of their fear of having their ventilator reallocated to somebody else. And the entire ventilator allocation guideline process has been murky and without clarity from the beginning. It's kind of a violation of transparency, which is one of the primary ethical principles that they were trying to uphold. So this is a concern for many people, but it's a concern of mine. So here's a picture of me in the hospital just recently. Actually, I had to go into Stony Brook Hospital for a medical procedure, and it was one that I had to wait many months to have done. It was supposed to happen way back in March, but given the pandemic, had to be rescheduled until the summer, and then ultimately in September. And it was quite a concern. There was I was sick for a number of months and was fearful all that time about how I might be affected by these guidelines, whether I was at risk of having my ventilator reallocated to someone else. So very briefly, these New York State guidelines are progressive, are broad, were well intended, but there needs to be clarity put into them. There needs to be greater transparency and the inclusion of the voices of people who are most directly impacted by a scarcity of ventilators or a scarcity of any kind of medical resource, healthcare resource, so that there is not this problem moving forward. And should that happen, should these guidelines be crafted in a clearer and more comprehensive way, that could be the model for other states to follow. Thank you.
Thank you, Brooke, for highlighting the issues with the ventilators, guidelines for ventilators use and allocation during the COVID-19 pandemic, and the ambiguity that exists in New York about the allocation of those. I will open now a discussion for questions and answers. If you have a question, can you please raise your hand? I hope that's possible in this Zoom. So I don't see yet any raised question. I have a question myself, Brooke. Sure. Maybe I will start. So did you get any information on why the guidelines have remained ambiguous? I mean, what's the advantage, if any? Mm-hmm. And are there any good practices on how to better reduce the ambiguity on the allocation of ventilators, either elsewhere in the United States or even in the world?
Mm-hmm. Sure, and I think that's a very valuable point and a very important question to ask. There's not really a clear reason why they've been so ambiguous and why there has not been more of a push to very clearly delineate in what instances the guidelines would be administered or for what population. And actually that has been a source of concern among many task force members themselves. They've been concerned about a lack of clarity and a lack of process in terms of how these guidelines would be integrated into standard of practice. These guidelines actually are completely voluntary, and that is problematic in and of itself. There's not a consistency or standard that hospitals in New York State or really anywhere have to adhere to when it comes to how they allocate ventilators. So because of that, it actually increases concern among ventilator users and really anybody because there's not clarity or certainty in terms of what hospital one might find him or herself and what the policy is that hospital is abiding by, and that's very frightening, right? So if I were to go essentially to Northwell, the Northwell healthcare system, or NYU Langone, I would be completely in the dark in terms of what process they're following, what guidelines they're following, and that's troublesome, that's problematic. And I think task force members have recognized that now, have understood that that people in general don't really understand what the guidelines are designed to do, or how they affect their lives, and even what institution is following what guidelines at all. So there has been a bit of a mobilization and some groundwork done among task force members to actually clarify these things. I think when the guidelines were originally crafted, it was almost an abstraction, right? The threat of a pandemic was a hypothetical, an abstract concept, not necessarily something that was immediate or very much present in our lives. Now that we are experiencing it firsthand, I think the failures of the guidelines or the problems therein have been brought to light, and maybe they didn't quite see them before because they never really had to look.
Okay, thanks for this additional information.
Mm-hmm.
I myself had not, only now I have become aware they are also voluntary. So it's not only the issue of the ambiguity of the guidelines, but you know, anyone can do whatever they want, the health facilities. Any question at this point for Brooke? So I don't see any questions. We are also on time to continue to the second paper. This paper is entitled Constructing the Support System with Chinese Characteristics for the Disabled under the COVID-19 Pandemic Period. This paper was produced by Zhu Wenxuan, Yanxiao, and Jiang Chuanzeng. And so I will invite Zhu Wenxuan, please, to present us this paper.
Distinguished hosts, professors, and fellow students, good morning. I'm Zhu Wenxuan, a graduate student specialized in social work at Wuhan University of Technology. And I'm very honored to share my paper with you here. This paper is a collaboration with Professor Jiang Chuanzeng with relevant data and support from the Hubei Disability Federation. It is gratefully acknowledged. This paper focuses on the issue of social support for the community of people with disabilities in China on COVID-19. I will briefly elaborate on this issue in the following 4 areas. Firstly, the first part is the introduction, which briefly states the background of the article, the purpose of the study, and the research method, which give you a general idea of this article. With the spread and aggravation of the COVID-19, the social relief work for people with disabilities under the epidemic has been attracting increasing attention. China's experience in disaster relief work for people with disabilities is still inadequate, and the challenges people with disabilities face is even more prominent in this epidemic. In order to effectively improve the quality of social support for persons with disabilities in disasters, this paper attempts to analyze the dilemma and the problems of people with disabilities in the epidemic, summarize and analyze effective practice and mechanism for supporting people with disabilities in the unique way of China, and come up with concrete countermeasures to improve the social support for people with disabilities. In the second part, I will present the data related to people with disabilities in the epidemic. As of 31 March 2020, Hubei province had a cumulative total of 608 COVID-19 positive cases of people with disabilities, accounting for 3.8 per 10,000 of the total number of the officially registered disabled, with 66 deaths and a mortality rate of 10.9%. Among them, a total of 398 persons with disabilities were diagnosed in Wuhan, accounting for 18.4 per 10,000 of the total number of the licensed disabled in Wuhan, with 50 deaths and a mortality rate of 12.6%. The proportion of diagnosed cases of people with disabilities in Hubei province was significantly lower compared to the proportion of the total infected population. However, compared to the general population mortality rate, the proportion of deaths among people with disabilities was higher. The reason may be related to their poor physical condition and underlying diseases. As shown in Table 1, the percentage of diagnosed cases of people with disabilities in Hubei province is much lower than the overall diagnosed prevalence rate, which it indicates that the social security and support received by people with disabilities plays a role in protecting their health. And this bar chart is about the disability category distribution of a diagnosed disabled person in Wuhan City. The third part presents the dilemma and the social support of people with disabilities on COVID-19. According to our survey, the dilemma of people with disabilities is reflected in the following 5 areas. The first one is information access and exchange dilemmas. As city locked down, direct social interaction was limited. Access to information among people with disabilities was not timely and comprehensive. The lack of an accessible medium for the exchange of information created barriers to their communication with hospitals and services, which also affected medical treatment and related services. The second one is the difficulties in stockpiling and accessing household goods. Owing to barriers to the access to information and cognitive limitations, people with disabilities was unable to stockpiling. They were unable to stockpile sufficient household necessities and protective goods, such as masks and alcohol, timely. Online good purchase are difficult to be used for the older and mobility limited disabled. The third difficulty was due to the transportation restrictions, the supply channels for essential supplies such as assistive devices and special medicines for people with disabilities was blocked, making it impossible to obtain them immediately. In addition, regular support and services offered to them in need were also largely unavailable. The fourth is dilemma of economic resources. In the locked places, the price level was 30 to 50% higher than usual. Even normal people was hard to afford it. In addition, many small and micro enterprises have been closed down. That means many jobs were lost, leaving people with disabilities without economic resources. The last one was the dilemma of psychological assistance. Living in isolation and limited access to information about the epidemic led to mental illness such as anxiety and depression. So, in the face of such difficulties, the government and the relevant units, departments, and organizations have taken positive measures, building a social support system in China's unique way. The social support, both formal and informal, was provided. Formal support comes mainly from the government, formal organizations, and communities. The government provides legal and policy support, financial subsidy, education and employment assistance, and some professional services. The communities provide personal information, registrations, transmit epidemic prevention information, assist in the purchase of daily necessities and medicines, community care, and also nursing service. Informal support is provided by social organizations, families, and the neighborhood. Social organizations provide professional assistance, volunteer care, accessible information, psychological counseling and assistance, home care and rehabilitation, personalized rehabilitation, and medical care. Families and the neighborhood, on the other hand, provide support in the forms of moral encouragement. Finally, there is a section of policy implications. First of all, improve existing laws and policies to provide institutional guarantee for regular social support. As a famous political scientist Fukuyama said, no set of existing laws or rules can anticipate all the rapid changes and new situations that countries will face. Therefore, we suggest that in the process of revising laws and regulations, we should make up for the shortcomings of social support and assistance for the needy groups. The second one, we should clearly identify the specific aspects of social support and provide multiple levels of social support. In addition to above-mentioned social support content, we should pay attention to and improve the provision of personalized rehabilitation, care, medical treatment, and psychological counseling, and other multi-level social support. The third one is build a social support network and clarify the responsibilities of each entity. A social support network for helping persons with disabilities in disaster situations should be established, comprising government agencies, organizations, professionals, and social resources, and the responsibilities of government. Also, Federation of Disabled Persons, the community and the social organizations should be clarified. The first one is accelerating the development of specialized social organizations for people with disabilities. Measures should be taken, such as publicizing different types of specialized social organization to society, encouraging the creation of private non-profit organizations that focus on specialized social work services, training relevant practitioners, and encouraging volunteers to actively participate in related volunteer activities. The last one is improving information network support, using information technology to build an information-oriented community assistance mechanism so as to achieve accurate assistance. Bill Gates, in an interview with White Rock, said China was the first country to set out to fight the epidemic. The countries that are the first to experience an epidemic often face the greatest challenges because people know so little about the disease. We hope that our research will provide insight into the unique way China is building of a support system for people with disabilities on COVID-19. Since the epidemic mainly occurred in Hubei province, the data and the information collected in this paper are mainly representative of Hubei province, which has certain limitations and therefore should be interpreted with caution. And that's all about my paper. Thank you all.
Thank you so much, Zhu Wenxuan, and thank you also for keeping the presentation within the 15 minutes time. Let me open this for discussion now. Any questions or comments or suggestions? So I don't see any question at this point. Wenxuan, I have a question. You presented a very impressive paper that's with a lot, but it seems to be a very complex system of support to persons with disabilities, from families to government, including formal and informal assistance. This would suggest that such a complex system does encounter some challenges to put in place. Have you investigated or could share with us some of the challenges of putting such a complex system in place?
Sorry, can you speak slowly? I can't understand.
Of course, I will repeat my question, and I will also add that there is a second question from Xie Yuhei. So I will put both questions so you can address them at the same time. So my question was, what were the challenges of putting such a complex system of support to persons with disabilities in place, both at the family and the government level? And I have a second question for you. It's what are the differences in support system in more developed cities and in less developed cities in China? So I will rephrase. So what are the differences in the support system between more developed cities and less developed cities in China? Please, Wenxuan, let me know if I need to repeat anything.
I think I can answer the second question about Xie Yihui. What are the difference in support system in more developed cities and not in the less developed city in China? I think in the more developed cities, the systems was more comprehensive and but in China, in its unique way, there is a pilot method. For an example, in Shanghai, Shanghai is a very developed city in China, and in this city, we have more developed services, institutions, and more medical services. Their experiences in social support or disaster relief work is it should be publicized, and these less developed cities, such as in the country, they are about to learn more about the advanced systems in the developed cities. I think this question is worthy a depth study, but I know just a little about this. Thank you for his question.
Thank you, Wenxuan, for these thoughts on the differences between more and less developed cities in China and the resources available in more developed cities that may not be available in less developed cities. I will now continue with the third paper and final paper of this session. This paper is titled A Pre-COVID-19 Assessment of Disability Inequalities in the Global South. It was prepared by Wei Chen, Justine Hervé, Sophie Mitra, and Jaclyn Yap. I understand there are 3 presenters of this presentation. I don't know who will go first, so I'll let you just go ahead, whoever is first, please.
sorry, so I'm going first. I had difficulty unmuting myself. But good morning everyone. I'm Jaclyn Yap. So I will be starting this presentation and then I will turn it over to Wei and then to Justine. So this is a co-authored work with the two of them and also Sophie Mitra. So we are from Fordham University, Department of Economics, and we also want to acknowledge funding from the World Bank and a philanthropic foundation. So our work is an assessment of disability inequalities in the global South. So the focus of our paper is pre-COVID-19. And so just to begin, I want to start this with a context of, so according to the United Nations Development Program, the pandemic is expected to worsen inequalities. So inequalities, not just in terms of income, but in terms of education, employment, and even housing conditions. And so before the COVID-19, there are already, as I will show you later, there is already an existing disability-related inequalities. And in some studies, we've seen that there is not a lot of disability inclusive responses or programs and policies for COVID-19. So one reason for this is probably the internationally lack of comparable data and statistics on disability. So, which is partly because of lack of attention and disability-related inequalities, although there has been some progress in this front. But so if we want to be able to achieve the 2030 Sustainable Development Agenda of leaving no one behind, we must also make sure to monitor the indicators and Sustainable Development Goals across disability status. So to move on to our research question, we want to look at the prevalence of functional difficulties in the global South. So we are looking at censuses and nationally representative data from 2009 to 2018. And we also want to look at the indicators associated with functional difficulties, inequalities associated with functional difficulties. So in terms of our data, so we looked for data sets and surveys that has the Washington Group short set questions. So just to give you a little background, this is 6 short questions regarding any difficulties experienced in the 6 basic universal functioning or actions. So seeing, hearing, communicating, concentrating, remembering, mobility, and also self-care. And so these are so if these data sets include these questions or similar questions, I'll elaborate a little bit on what we mean by similar in the next slide. So these are the ones that are included in our sample. And so we have 20 countries and several indicators, which include some SDG indicators that can be answered by these data sets, but also beyond that. So we have employment, education, living conditions, assets, foods and security, exposure to shock. So we have a limited time today, so we're only presenting the major ones. And we also want to note that we look at individual and household levels. And so for individuals, we have a cutoff of 15 years and older because the WGSS is adequate for adults. In terms of our data sets, we used 5 different types of data sets. So we have 22 here because 2 of the countries have 2 data sets. And so we have the census, the living standards measurement study survey, the household income and expenditure survey, the living conditions survey, and the labor force survey. And so those with the asterisk, which is a lot of them are in the right side. So they have either the Washington Group short set or at least 4 out of 6 of the questions. So this is what we're defining similar to be. Or if they have the Washington group short sets, but their answer scale is different from the recommended Washington group short set, so we're including them too. So some of them, for example, in the censuses, they have the short set questions, but they only have a yes, no for an answer instead of the typical 4 level scale. So to just present the prevalence, this is the prevalence of individuals with any functional difficulties in the different countries. When we say any functional difficulty here, it's an individual that answers, so either at least some functional difficulty, that they're experiencing some functional difficulty for at least one functional domain or functioning, or they answer yes if there's only like a yes or no. And as we can see here, the highest prevalence rate is for Papua New Guinea at 28%. But I think we should also note that the next highest here would be Namibia and Uruguay, which is about 19%. So there is some difference in the maximum. And this might be because that Papua New Guinea actually has a reverse scale, where instead of 4 having no difficulty at all, for them it's 1. So that might play a factor into that. And the median for prevalence of any functional difficulty is at 12%, and the lowest here is about 4% for the Philippines. So we also looked at individuals with a lot of difficulty or unable to do so, the ones with a little more extreme experience of difficulty. And we see that the numbers are smaller, but still significant if you look at it in terms of the absolute value. Again, we have Papua New Guinea here at 5.9%. But here, I wanted to highlight that Uruguay has 5.7%, which is not too far from the maximum. And the lowest here is Vanuatu at 0.8%. And the median is at 2.9%. So I didn't talk a lot about the countries that are here, but so we have different representative countries from different parts of the world. So we have some from South Asia, East Asia, and the Pacific. We have sub-Saharan African countries and Latin American countries. And we can also see here in the individuals with also this extreme measure of persons with disability or the prevalence, we see that we don't have the countries with the yes or no indicators anymore. So there are fewer data points. And so this is just a household with any functional difficulty. So basically we're just documenting the number of household who has a person with disability, with any functional disability in that household. So we can see that they're higher. And so the median for this is at 20%, 26%, with a maximum at, again, for Papua New Guinea for more than half, so at 55%. And the lowest is Indonesia at 9%. Okay, so in terms of distribution of the functional difficulties, here you have the 6 domains. And this is a little difficult to read, but basically if you look at the distribution, we see that the majority of functional difficulties is coming from seeing, which is the blue at the bottom, and hearing, which is the orange. So I turn you now to Wei for the indicators.
Thank you, Jackie. So I would briefly describe our results on the SDG indicator Jackie just mentioned by a series of bar charts. Just keep in mind that if you see the orange bars that present people with disability and blue bars present people without it. So first, this graph indicate the gap in education attainment measured by the average attained school rate in 20 countries. As you can see that the results consistently point at significantly lower rate for person with disabilities. And the largest gap is observed in Bangladesh, which is 26%. And then the smallest difference was also 5% from Kiribati. So these results are in line with intensive evidence that adults with disability have lower education attainment in low and middle income countries. So next. Next, please. Thank you. So this bar chart here presents the gap in employment population ratio in the 20 countries. Differently, the gap varies a lot across countries. So the difference is marginal in low-income countries of Africa, such as Liberia and Gambia. It's larger in middle-income countries, for example, Indonesia. That is consistent with the disability and development hypothesis that disability inequality widen with the development. It's also worth mentioning that the largest gap are in South and Central American, for example, Mexico and Panama. Also, that's also where the pandemic has had a devastating health and economic effect so far. Next, thank you. So this graph shows the gap in the share of individuals having food insecurity. We define someone is suffering food insecurity if they decline not having enough food to eat or having to constrain their food purchases for some time in a month. So the highest share of individuals having food insecurity is Nigeria, where the gap here is 14%. This result indicate that in all countries, households with functional difficulties are more prone to food insecurity. And in the paper, we also look at the different level of difficulties. It shows that no matter the level of functional difficulty, this difference remains. Next. So the next two slides show the living conditions and the level of having asset for a household. First, living conditions are measured by whether having clean drinking water, sanitation, electricity, clean fuel, good material for roof and wall in the household. So the difference is not statistically significant for all countries. However, consider them all together, individuals with disabilities seem to be on average more prone to unsatisfactory living condition in most countries. Next, please. So a similar picture is seen in terms of the assets. So we find that households with people with disabilities seem to own consistently less asset than households without it. Although, as you can see here, the gap are smaller than other indicators. Next, please. So finally, given the disadvantages seen earlier, a household with disability more likely to benefit from social protection. So our answer is yes in most countries. Except Malawi and Nigeria here, we find that there is no statistically significant difference. The chart indicates that in general, households with functional difficulties more often receive social protection benefits. That's all for the indicator. I will pass to Justine.
Just a kind note that you have 1 minute left for the
presentation. I'm concluding, so that's good. So to conclude, like the main motivation of this study is that we still have there's still a little attention given to inequality-induced disability in policymaking in the Global South. The main reason behind this observation is that there's a lack of internationally comparable statistics on disability globally. Now, this project tries to address this issue by improving the availability and the quality of statistics on disability, but also on the socioeconomic lives of disabled people. in the main conclusion we find here is that in the 20 countries that we study, functional difficulties are actually pretty common among adults and households. And we also find a significant and consistent positive association between functional difficulties and socioeconomic deprivations. If I detail those subjects, results, sorry, very quickly, among adults, we find that functional difficulties are significantly positively associated with lower educational attainment, but also lower employment population ratios. And at the household level, we find that household members with functional difficulties are more economically insecure, which is measured by the level of food insecurity or exposure to shocks. But they also have like worse living conditions, fewer assets, and higher health expenditures. These results are actually valid no matter the stratification we use to define disability. So whether we use no difficulty versus any difficulty, or no or some difficulty versus a lot of difficulty, those results still remain. Now, in terms of policy implication, we just told you that adults with disabilities are overrepresented among the population with lower socioeconomic status. Given that the COVID-19 pandemic is expected to increase economic inequality, it means that this population, the population of disabled individuals, is particularly vulnerable facing the current circumstances, and that therefore governments should prioritize the provision of disability inclusive policies when developing COVID-19 policies. Thank you.
Thank you to the three presenters for this comprehensive presentation, giving us the feedback, the technical feedback on the sources, as well as the challenges in many indicators, and also what conclusions can we take from it. Let me ask if there are any questions, suggestions, comments at this point. So I understand people can ask questions in the Q&A chat box. So while we wait for some maybe reflection among everybody, maybe let me ask, and I'm not sure which one of you, but are there any past studies made during crisis, financial crisis or other pandemics that used pre-inequality data and tried to estimate how a pandemic can exacerbate these inequalities in a quantitative way? And could this be done for this pandemic?
So, I mean, to be honest, I'm not sure about previous studies that did that for, let's say, the Great Depression. But in our case, it is possible, and that's probably our objective, to do an assessment of pre-COVID-19 inequalities and see how this changes after. Except that we don't have the data yet for that, but that's definitely that would be an interesting exercise.
Just to corroborate that, I mean, there are certainly standard metrics that are found in the SDGs. Those are typical for development, but I think we're still learning about it and understanding the multidimensional ways that people with disabilities have been impacted by the COVID-19 pandemic in ways that we possibly did not understand before. So, in the case of the paper that Dr. Ballan and I have put together, right, they're a disproportionate opportunity of receiving scarce medical resources. That's an issue that possibly was not conceived of when the SDGs were originally being crafted. The same thing when it comes to additional economic expenses that might be incurred by people with disabilities in the time of the pandemic that maybe need to be thought about a bit differently than how we've approached these problems in the past. So I think that this pandemic has really opened up many people's eyes when it comes to how we need to think much more comprehensively about the factors that affect the lives of people with disabilities above and beyond the ones that we typically employ to assess inequalities or development.
Thank you, Brooke, for highlighting that sometimes we need to go beyond the SDGs to really understand the inequalities that persons with disabilities may face during the COVID-19 pandemic. Let me see if any of the authors or presenters have something to comment on that.
So we also, well, this is COVID-19. It was published in May, so it was in the context of the pandemic. It's not exactly looking at disability inequalities, but so this paper that I co-authored with Sophie and also Vandana and some other co-authors, we looked at how the COVID-19 press conferences were inclusive with regards to hearing impaired communities. So basically, if they had like the inset, and if this was available in low and middle income countries, so basically the global south, and we found out that there wasn't a lot. So this is with regards to information dissemination policies, and even in that front, I think they have to be reminded that there are people in the communities who are differently abled.
Thank you, Jaclyn, for this addition. And this would definitely cause an inequality already in the access to information. So I have 11:32 a.m. New York time, so I think we are due to close this session. Thank you so much to all the presenters and the participants. This was an excellent session about an emerging topic. This discussion will not end here. We will have to continue. And I'd like to thank the Fordham University for organizing this session on this important topic, because this is a discussion that needs to happen if we plan to respond in a disability inclusive manner in the next months and even years as we recover from the pandemic. So thank you so much to all. I wish you the best in the continuation of your research, and bye-bye.